Hello, my name is Bria Brooks. I'm a PharmD candidate, and today I'll be discussing tardive dyskinesia. The learning objectives for today are to identify medications or drug classes that can cause tardive dyskinesia or TD, list signs of TD, recognize the TD treatment options and limitations to those treatment options, and describe TD prevention strategies. So we'll start off by going over what exactly tardive dyskinesia is, or TD. I'll be referring to tardive dyskinesia as TD for the rest of the presentation. TD is a drug-induced, potentially irreversible disorder characterized by involuntary movements of the oral facial region. It's caused by medications that block the dopamine receptors. Our most common offender is antipsychotics, particularly the typical first generations or aka neuroleptics. However, second generation antipsychotics or your atypicals can also cause it as well because they also block dopamine receptors at a much lesser affinity. In addition to antipsychotics, we also can see it sometimes be caused by metoclopramide as it blocks dopamine receptors as well. So looking at antipsychotics, since we typically see it in antipsychotics, TD occurs in around 20% of adult patients who take antipsychotics. And our antipsychotic use, albeit it's with second generations primarily, is increasing in our pediatric population. TD can have an impact on the patient's quality of life. It can cause a lot of self-isolation and embarrassment, especially in our kids. Having those involuntary movements can be very embarrassing. The exact pathophysiology of TD is not completely understood. However, the overall idea is that prolonged blockage of the D2 receptors in the nigrostriatal pathway, which is responsible for our movement, the blockage of these receptors causes an upregulation of receptors, which eventually causes supersensitivity and consequently hyperkinetic movement. The binding of the D2 receptor plays a role in the prevalence of TD. For instance, first-generation antipsychotics bind D2 receptors with very high affinity, whereas second-generation antipsychotics bind with less affinity, and they don't bind to the binding site as hard and hold on as strong. Additionally, second-generation antipsychotics bind 5-HTT2 serotonin receptors, which is thought to have a protective effect over the development over TD. So factors that may increase your risk for getting TD include being female, being of African descent, increased age, having a history of EPS symptoms, such as maybe when you first started the medication, a mood disorder, diabetes, long treatment duration, and or a high dose. As I previously stated, TD is typically seen firstly in the oral facial region. You may see involuntary sticking out of the tongue, smacking or puckering lips, grimacing, rapid blinking. In more severe cases, you may see chorea or jerking of the extremities as well as some truncal involvement. The symptoms of TD may ebb and flow. For instance, when a patient is under high anxiety or high stress, they may find that they're experiencing TD symptoms more often. And vice versa, if they're very distracted or very focused on something, for instance, if they're doing homework, there is some research that suggests the symptoms may be lessened at that point. The thing with TD is it does have a very insidious onset. It may take a while before the patient recognizes the symptoms. To diagnose TD, according to the DSM, you need to have at least a few months use of a neuroleptic agent, as well as symptoms that persist 4 to 8 weeks beyond discontinuation or dose change. If it resolves within that 4 to 8 week window, it's considered withdrawal emergent dyskinesia, which is a different syndrome. The abnormal involuntary movement scale, or AIMS, as well as the dyskinesia identification scale, condensed user version, are important screening tools both in the diagnosis and monitoring of TD. The DISCUS screening tool is used for those who have developmental delays. Once TD has been recognized, it's recommended to stop the offending agent, reduce the dose, or switch to an atypical antipsychotic if a typical antipsychotic was initially used. With that being said, this is not all the time feasible, as sometimes the patient needs the medications that they are taking. Unfortunately, evidence-based treatment for TD is severely lacking, especially in our pediatric population. There's currently only 2 medications that approved to treat TD, but both of those were not studied in the pediatric population. And even with treatment, even if you stop the offending agent and reduce the dose, the symptoms may not resolve completely. The first approved medication we're going to look at is Valbenazine or Ingrezza. Valbenazine is a VMAT2 inhibitor or vesicular monoamine transporter 2 inhibitor. It acts by reducing the modulating the dopamine going into the synapse. Valbenazine was approved in 2017. The CONNECT trial, which showed its efficacy, was a phase 3 placebo-controlled randomized controlled trial. 205 patients who were over the age of 18 were enrolled. They had to have had schizophrenia, schizoaffective disorder, or mood disorder, along with moderate to severe tardive dyskinesia. The primary endpoint of the study was to evaluate the change in baseline AIM scores after 6 weeks. There were 2 dosages used, and the patients were assigned in a 1:1:1 ratio. And as far as the results, both groups of dosage in the valbenazine group did have a statistically significant difference in their AIM score. The 80 milligram group reduced the AIM score by minus 3.2 points, and then the 40 milligram group reduced their score by minus 1.6 points. Both of these were statistically significant, as I said. However, I do consider the 80 milligram really the only clinically significant one. The valbenazine in the trial was shown to be pretty well tolerated. There was some somnolence, dry mouth, and akathisia. And once again, I do want to note that it was not approved in pediatric population. The next medication that we're going to look at that was approved for the treatment of TD is Deutetrabenazine or Austedo. This too is a VMAT2 inhibitor that was approved in 2017. It comes from tetrabenazine. It was being considered for treatment, however, it showed poor pharmacokinetic parameters. The deutetrabenazine contains deuterium, which kind of helps aids in minimizing those pharmacoparameters that were limited with the tetrabenazine. The ARM-TD trial was a randomized controlled trial with 117 patients who had AIM score greater than or equal to 6. The primary outcome was an evaluation of AIMS after week 12. In looking at the primary outcome, there was a significant difference between the treatment group and the placebo group. The deutetrabenazine group had a reduction of about 3 points, whereas the placebo group had a reduction of 1.6 points. This is both statistically and clinically significant. The side effect profile was pretty similar as to what it was in the valbenazine group, with the drowsiness being noted. There wasn't really any increase in psychiatric adverse events noted either. And just like the valbenazine, this one isn't approved in children either. Other treatment strategies that have been looked at and have shown some efficacy include clonazepam, ginkgo biloba, amantadine, tetrabenazine, as I previously have mentioned, vitamin B6, and haloperidol. With these medications, however, the trials have been very, very small, and the information is kind of weak, but they have shown some efficacy. The American Academy of Neurology actually does recommend clonazepam and ginkgo biloba with the weak recommendation for the treatment of TD. A couple other medications were looked at, including Keppra, fatty acids, and melatonin. and these were found not to have a very strong benefit. In very severe cases of TD that's treatment refractory, deep brain stimulation has been shown to have some benefit. One thing I would like to mention is that anticholinergics are sometimes used either for the prevention and or for the treatment of TD, and this practice is not recommended. There's conflicting data, but there is some thought that anticholinergics may actually increase the risk of TD, so we don't want to use them. They do have a role in other EPS syndromes as far as treatment goes, such as in Parkinson's and dystonia. However, in TD, we don't want to use it as treatment or as prevention. With all this being said, I once again want to reiterate that the treatment evidence is very, very weak, and there's very little information on pediatrics, and then even in these cases, it's hard to expound it to pediatrics because many of these trials were involving schizophrenic patients or those with schizoaffective disorder, whereas the treatment of antipsychotics in our pediatric population is typically for off-label uses, and so it's those populations even beyond age are not the same. So like I said, the evidence-based treatment of TD is very limited, and so our main focus is prevention. When using dopamine blocking agents, you want to be very judicious in your use of them. You want to use medications at the lowest effective dose. And if you're going to use an antipsychotic, you may want to consider atypical, although those do come with their own set of risks. If you're going to use any medication, whether it's atypical or typical antipsychotics or metoclopramide or any other medication that could potentially cause TD, you do want to monitor for movement disorders. Typically every 3 to 6 months is recommended. The reason for this is that there has been research that's shown that there's an inverse relationship between remission rates and the duration of TD. So if you're able to get it in check early, you may have a benefit of possibly resolving the TD. And you can monitor with the AIMS or discuss, or even if it's just talking to the patient or parent to see if they've noticed any movement changes. So to tie it all together, TD is a potentially permanent movement disorder that is caused by medications that block the dopamine receptors. It's characterized by involuntary movements of the face, which may extend to the extremities and truncal region. The AIM screening tool should be used to screen and monitor regularly, and the prevention is key as evidence-based treatment options, especially in the pediatric population, are limited. Okay, so now I have some self-assessment questions. The first question is, which medication is most likely to cause TD? The answer to that is haloperidol, as it is a first-generation antipsychotic. Oddly enough, it can be used in a treatment as well, though. Question 2 is, tardive dyskinesia primarily affects the lower extremities. True or false? This one is false. It primarily affects the oral facial region, as I stated. 3. What 2 medications are FDA approved for TD treatment, and are these medications approved for use in pediatrics? So A is Deutetrabenazine and Valbenazine, and yes, they're approved in pediatrics. B, Deutetrabenazine and Valbenazine, no, they are not approved. C, Tetrabenazine and clonazepam, yes, they are approved. And D, Tetrabenazine and clonazepam, no, they are not approved in pediatrics. And the answer is B. Deutetrabenazine and Valbenazine are currently the only medications that are FDA approved, and neither is approved in pediatrics. So question number 4, which screening tool can be used to screen for and monitor movement disorders? AIMS, DESC, GDS, or SEEK? The answer is AIMS, the Abnormal Involuntary Movement Scale. So here are my references. And if you have any questions, feel free to email me at bria.brooks@ttuhsc.edu. Thank you.